just want to make sure we all understand how all these terms fit together. I really don't have a good illustration. That's what I was looking at. I was looking for a better illustration. I thought I'd placed one in here. But some of you were asking about the punctum. The punctum would be here. You can have here's the punctum anatomically. That corresponds to this structure. And so you can see what's happening is the tearing that's suffusing or covering the eye from the lacrimal gland in the upper outer region here is going to be aggregating at this little lake down here. And then as it does so by the canthus, it enters the punctum. And then that is the little canaliculus that conveys it to the sac, the duct, and then eventually into the nose. All right. So as I say, I have several illustrations of this. In fact, you can see that here's a larger illustration of the same thing. But if you look up here at this sort of sagittal section of the lid, now notice the remarkable interdigitation of the structures we've talked about. So here's the levator palpebrae here. That's that fairly large skeletal muscle that's important for elevation of the eyelid. Here's the tarsus, sort of interior to that. And then this whole thing is called a tarsus plate. So here's the tarsal muscle, and you can see it sort of disappears in this illustration. This whole thing is called the tarsus plate, and then embedded in that tarsal plate are the tarsal glands, also called Meibomian glands, that when they are inflamed and swollen, form a chalazion. But this is the location. It's the interior of the eyelid. All right, so that's the levator palpebra here, and then you can see it sort of interdigitates with components of the palpebral part of the orbicularis. So here's the orbicularis out here, levator, orbicularis, tarsus. And this is the component that is innervated by the sympathetic nervous system, this little region here. And that's why the sympathetic ptosis is relatively minor. Again, normally no more than 20% of this. Now, in addition to these tarsal glands being inflamed, and you hear the tarsal glands here, the glands down here, which are called ciliary glands, at the sort of the margin of the eyelid, can become inflamed as well. Those are called moles glands, or ciliary glands, and that gives rise to the stye that you're probably familiar with. And you have several examples of those. Innervation to this region. Sensory, again, branches of cranial nerve 5, V1 and V2. It should surprise you, the ophthalmic is involved here. Motor, cranial nerve 7 for the orbicularis oculi, the palpebral auriculus oculi, and then cranial nerve 3 for the levator. And that's, so be sure you know that. And we've already talked about the tarsus and sympathetic innervation there. There are extremely large textbooks, very large textbooks that will keep your head spinning regarding autonomic innervation of the lacrimal glands and the ability of the eye to regulate the fluid that's moving across the eye and the fluid that's moving across the membrane of the eye. So there are a number of regulatory systems involved in that, but the autonomic plays a large part. So we're not going to get into that very, very complex discussion in here, but I do remind you that, remember, the parasympathetic division is primarily responsible for tearing, for production of tears from the lacrimal gland. And you actually have this pathway charted elsewhere in your notes, from the facial, the greater petrosal nerve. We talked about piggybacking on the facial. And then down to the pterygopalatine ganglion. and then from the pterygopalatine, where there's a synapse from the preganglionic, it comes along the maxillary nerve, the branch of 5, down to the lacrimal gland. So we've also mentioned Horner syndrome. Just to remind you that that's maybe worth knowing in here as well. We've talked about these terms. You should be able to define these terms now, meiosis, ptosis, and anhidrosis. Once again, these won't always be present in Frank Horner syndrome, but they may be. I'll leave it to your clinical courses to differentiate the various types and stages of Horner's. But we've talked about the pupillary constriction, loss of the ability to elevate the eye completely, and then the anhidrosis, the ipsilateral loss of perspiration, potentially. But remember, the ptosis can also result from issues involving the facial nerve, the oculomotor nerve, or as we've seen in Horner's, sympathetic fibers involving the superior tarsal. We've often made the distinction in here between intrinsic and extrinsic structures. We talked about intrinsic and extrinsic muscles of the tongue, for example. Later we'll talk about intrinsic and extrinsic muscles of the back. Similarly, when we talk about the eye muscles, the intrinsic muscles regulate the shape of the lens and the size of the pupil. The extrinsic muscles, on the other hand, are positioning the eye, actually responsible for moving the eyeball. And you can see some of these on the illustration here. You can see the levator palpebrae and its relation overlying the superior rectus, the inferior rectus here. So those would be examples of extrinsic muscles. You have several illustrations showing some of these. Again, superior rectus, lateral rectus, the inferior oblique, the superior oblique over here passing through the trochlea. We talked about the trochlea as a useful mnemonic for remembering the trochlear nerve. Now, there is a brief discussion in these few slides discussing the terminology of eye movement. Be sure you appreciate, as you look at the organization, the distribution and attachment of these muscles. We're looking primarily at the rectus muscles here, superior, lateral, medial, and inferior, that you appreciate that eye movement, positioning of the eye, is not simply contraction of one muscle and relaxation of the other. It's infinitely more complex. And again, it involves tonic contraction of virtually all of these muscles with combinations of very, very complex relaxation. But in general, elevation is upward movement of the eye, depression is downward movement, abduction lateral, and adduction medial. When we talk about rotation of the eye, internal rotation is the top moving toward the nose, again, rotation, top toward the nose, external rotation, top toward the temple. Now, there's a little discussion of the muscles in terms of their innervation. But in these pictures, in these slides, what I would charge you, make sure you can do this, is make sure you can label some of these important muscles in an illustration like this. Be able to differentiate, for example, the levator palpebrae from the superior rectus, lateral rectus. If the image shows the medial rectus, and so on. Remember, we said earlier that orbit has a pyramidal shape, the base of the pyramid anteriorly, and then the apex of the pyramid pointing to the back of the eye. And the idea there, that's called the common tendinous ring. That's where most of these muscles, the tendons that supply the origin of these muscles occurs. And then you can see the attachments peripherally in this illustration down here. So this would be that common tendinous ring back here. There's several check ligaments that inhibit excess movement of the eye, especially in the lateral and medial direction, that limit the contraction of the lateral and medial rectus muscles. And once again, that common tendinous ring back here for both neuro and muscular structures. So there's a table here discussing the nerves involved in the various muscles, and I think we've talked about this sufficiently. You can see the innervation of each of these muscles here. There's a very simple mnemonic. I have it on one of these slides here. that you can use. Oh, that makes sense here. Why did I have it so far back? But you already know. We'll get to it in just a moment. But again, example of some of the movements of the eye. Don't be too concerned about attempting to explain. I'm not going to ask you which muscle is responsible for medial rotation or even abduction, because again, it's much more complicated than the terminology suggests. Just be familiar with what is meant by depression, elevation, abduction, and abduction. And then if you saw an image such as this, you should be able to identify the muscles shown there. There's a little animation up on the website we can play around with. See, I can have the eyeball scan you right now. And then you can see the relationship of these muscles, superior rectus, lateral rectus, inferior oblique, and so on. Yeah, it should be up there in the animation section, media animations. I don't know what I do with my little mnemonic there, but anyway, the next few slides are just describing possible pathologies or deficiencies of either the muscle or the nerves innervating the muscles. We know that cranial nerve 3, for example, carries most of the work. It does most of it innervates most of these extrinsic muscles of the eye, and that can result in a variety of symptoms if that nerve is compromised in any way. You often get, depending upon the laterality of the injury, a variety of problems. Eyes not moving in tandem with loss of visual function, or to some degree of visual function. And then we talked earlier about either the muscle pathologies, neuromuscular pathologies, or as you see down here, some type of mechanical injury that ultimately results in entrapment of the muscle. The eye may be intact, even the skeletal. Well, that's usually not the case. The skeletal system is intact. But in some fashion, one of the muscles has become entrapped, perhaps by comminuted bone. Even if the nerve is telling the muscle to move, it's not able to do that. And there are a variety of palsies that can also give rise to the inability of the patient to track properly. So with respect to the intrinsic muscles, we talked about these in the physiology class. So you're familiar with the ciliary muscle, the ciliary body. You can see the iris extending from that structure. Here's the cornea, here's the iris here. And then you look over here at these little cartoon representations, you can see the 2 layers of smooth muscle that are responsible for regulating the size of the pupil. Remember, the constrictor muscles are, for the most part, responsible for decreasing the size, although I should mention, and I thought it was in here somewhere, almost all of the normal regulation of pupil size is parasympathetic, even though there is sympathetic innervation to the constrictors. And you can see the difference here. These are the constrictors. These are the dilators. Dilators are more, what's the word, longitudinal. These are radial. Previously, we looked at the ophthalmic artery responsible for perfusing most of the structures in the orbit. And you see some of that. You see some of the radiations here, the radiations of the ophthalmic extending, for example, to the surrounding extrinsic muscles. And several illustrations showing the same thing. There's a long list here of arteries or branches of the ophthalmic artery. You do not have to be able to name the branches of the ophthalmic artery. I think we mentioned earlier that the corresponding veins in this region are much more interconnected than the arteries. There is, for example, an anastomosis between the ophthalmic artery and the transverse facial artery, but that's comparatively minimal by comparison to the dense interconnection of veins around the eye. And so once again, this ophthalmic vein is going to drain the orbital socket, eventually back into the cavernous sinus. And remember, the blood in the cavernous sinus will eventually proceed inferiorly into the jugular vein. And we can even see that there's anterior drainage into the facial vein and into the retromandibular veins that we looked at earlier. Here we go. I was looking for this. Here's the mnemonic that all medical students remember. LR6, SO4, and AO3. What does that mean? Yeah. And then all others are 3. And so here you can simply see an Acklin. The Acklin videos give you a similar illustration of the relationship between these extrinsic vessels and some of the other structures too. You can see the proximity of the orbit. You can see to the cavernous sinus we mentioned a moment ago. You can see how the vein drains so readily into the cavernous sinus. You can see this periorbital fat, this adipose tissue that acts as sort of a cushion for the eye. A number of traumas can result in loss of that fat, and sometimes they have to take it from another location of the body and replace it. For this class as well, be sure you understand the general, not specific, but this is just a gross anatomy course, but be sure you understand the general neural pathway involving the eyes. You can see the right and left visual fields here. We talked about the optic chiasm, and we said in the physiology course that about half of the information from each eye crosses over. The other is ipsilateral. And as we pointed out before, the right visual field, information from the right visual field usually ends up in the left brain and vice versa. In the physiology, we also talked about the organization and the laminar structure of the eyeballs, so I don't think we need to spend a lot of time on this. As you can see, when we talk about the encasement of the eye, there are usually 3 major layers: fibrous, vascular, and then the retinal layer. You can see the fibrous layer here. Why, when they take your picture, do you have pink eye? Yeah, it's mostly those retinal capillaries, but sometimes, depending on a variety of factors, depending on again the species of the animal, that color will change. It won't necessarily be red. You probably shined your lights on a deer or something, a cat or something at night. Why don't they suffer from pink eye? Pink eye. I keep saying pink eye. Red eye. Pink eye. Or maybe they have pink eye and red eye. Anybody familiar with that phenomenon? You don't see very well at night. We don't have the ability to adapt. We'll talk about photoadaptation in the other course, but you don't see very well at night. Many animals, many nocturnal animals, inside their eye have a coating that's unlike yours, something called the tapetum lucidum, which increases the reflectivity of the light inside the vitreous humor. And as a consequence, they're able to retain and see a lot better light than you can, like your cell phone, right? Doesn't your cell phone see magically in darkness that you can't see? I'm sure you have a Galaxy S6. So you should be able to identify these structures. We talked about these: the ciliary body, the iris. What are these things right here called? Yeah, the zonula, the lens. You can see the optic disc back here. By the way, this is wrong. Actually, yeah, I don't like that. The problem here is it's calling it a cavity. I don't want to give you the wrong idea. Remember, this is the anterior chamber This is the posterior chamber, anterior, posterior. This is called a humor. So I'm not sure if I got this from a textbook or not, but I don't like that term at all. That sclera is the thick, dense connective tissue that forms the greater part of the encasement of the eye. And then the cornea overlies that, is adjacent to and overlies the visual portion of the eye anteriorly. And remember that as a non-keratinized stratified squamous epithelium. And then you can see here, you can see the fibrous, the vascular, and then the retinal layers. The yellow is the retina there. That vascular layer interior to the retina is called the choroid. And then we've talked about the ciliary body that responds to chiefly parasympathetic, but also sympathetic innervation. Yeah, we were talking about red eye a moment ago. We know what constitutes, was there a question?
Yes.
Yeah.
In respect to the iris, if it's a muscle, how come?
So the iris is sort of a smooth muscular tissue.
How come everybody has a slightly different color of that muscle?
Well, the coloration would depend upon pigmentation. Remember, we talked about pigmentation in our discussion of the integument. Earlier, we talked about various types of melanin.
Melanin, yeah.
And so, for example, we said there's pheomelanin, eumelanin, and there's another one. So, in general, if you have a lesser abundance of melanin in the integument generally, you're more likely to have a bluish iris. If you have greater pigmentation and a greater concentration of eumelanin, then you're more likely to have a brown coloration to the iris. But yeah, that's just the pigmentation of that tissue. Is there anything here we haven't talked about? You have the iris, the overlying cornea. I think we mentioned all of these. We talked, what's the fovea centrale? Actually, we haven't talked about that. We mentioned the difference between the fovea and the optic disc. Remember, the optic disc, there are no photoreceptors at the optic disc because that's where all these neural pathways aggregate. As I say, I think you're going to be surprised at the organization of the retina when we talk about that tomorrow. The fovea is where conversely, where there is the highest concentration of cone receptors in the eye. Cone receptors afford both color sensation and precision, discriminant vision. And this is properly labeled here. Remember, the vitreous body is back here. And then, yeah, we've talked about the sphincter and the dilator pupillae. I don't know if there's anything here. There's a little bit of a confusion with respect to the vascularity here. This is describing the choroid here, but these blood vessels are present exterior. How can I say this? There is a profusion of blood vessels posteriorly surrounding the exterior of the eye that is continuous. Do they show it here? Continuous with the choroid of the eye as well. So if you look at, for example, this blood vessel called the vorticose. This is one vessel. This is a vorticose vein that conveys the venous blood from between the exterior eye and the choroidal layer. So what we're saying is that there's extensive vascularity in both of those layers, and that blood is communicated by a variety of vessels that cross between the intervening membranes. So the retina is back here. That's the interior layer of the posterior eye. Anteriorly, that retina becomes something called the ora serrata. And the ora serrata is this sort of yellowish membrane that you see in here. It's a non-visual membrane. You wouldn't be able to see anything if it did have rods and cones in it because of its location. but it is continuous with the retina. When the optometrist or ophthalmologist takes the ophthalmoscope, invented by the man, I heard somebody talking about the otoscope. What's an otoscope? Yeah, and invented by the same man who invented the ophthalmoscope. Anybody know who that is? Hermann von Helmholtz. Also discoverer of the conservation of energy principle. He was a brilliant man back in 1848, I think. But in any case, when they take the ophthalmoscope and peer into your eye, what they're looking for is abnormalities in the distribution of blood vessels, chiefly around the macula, because this is the really critical region, because once again, that's where the highest concentration of photoreceptors is located. When we talk about macular degeneration, it is usually photo-associated deterioration of those rods and cones in this region. So the macula lutea, again, macula just means point, same sort of thing here. Yeah, so you can see here, there's clearly a change in the appearance of the retina in the region surrounding the macula. This individual, it's usually attended by a loss of photoreceptors, at least the photoreceptors no longer function properly. And so typically, individuals with this problem will only see a ring. In other words, the center of their field of vision is either absent, blurry, any number of problems. They don't, that very critical region that we all depend upon there at the center of our focus would be impaired in some way. All kinds of new procedures whereby information from the periphery, because you can't really replace those photoreceptors, but information of the periphery is connected to the neurons that carry information from the fovea. And so that the brain then is tricked into thinking that information is coming from the fovea, and your brain learns to get a more complete visual field. This is a brief discussion of retinal detachment. Let's look at this first. And this is going to give away my thunder tomorrow, because I was going to surprise and astound you with the organization of the retina. But these are the photoreceptors here. These are the purple things and the brown things. And first of all, one thing that should surprise you is this is the sensitive region here. Right? This anterior region is what is sensitive to light. We'll talk more about this later. And what do you notice about the light-sensitive region? What does it do? It buries its head in what's called the pigmented epithelium. It buries its head in the sand back there at the back of the eye. If you're going to sense light, does that seem to make any sense? It's crazy. But anyway, they're sticking their heads back in the sand back here. And by the way, all right, here's the photoreceptor. We don't really see it here. I don't think I have a picture here. But there are about 6 or 7 layers of cells down here at the bottom we're not looking at. Why is that surprising? Because this is the front of your eye at the bottom of the screen. The light is coming in from the bottom, moving all through those cells, and then finally making its way to the rods and cones. So your mystery for tonight is to explain how that's possible. How can you see anything when it is not only the fact that your rods and cones are sticking their heads in the sand away from the light, but there are several layers of cells down here that are obstructing the light. But here's the point we need to make with respect to the anatomy. We'll talk about that tomorrow. When we're talking about detached retinas, what I wanted you to see is that the term usually describes delamination of these structures. Again, you can see the pigmented epithelium. This is called the neural layer here, the outer segment, the intersection. That's the neural layer. And then, as I say, you're going to have a host of cell layers down here we'll talk about tomorrow. All right. In a retinal detachment, where would you suspect the delamination to occur? If you had to guess. And you have to.
In the outer segment?
All right, you're saying the outer segment separates from what?
The discs from the epithelium.
You're exactly right.
Good guess.
That is most commonly what occurs, yeah. And you wouldn't think that, because again, you would think that it might be the pigmented epithelium from the basement layer at the back of the eye. That sometimes happens, but there's a fairly strong connection. In other words, there's sometimes detachment up here, but that's comparatively rare because this is a relatively robust connection. For whatever reason, retinal detachments generally involve a region or area of separation of the rods and cones. Again, that's called the neural layer from the pigmented epithelium. And there are all sorts of amazing procedures that are now undertaken to correct that. And that can happen for genetic reasons, acquired reasons, trauma, any number of pathologies can cause that. This is the one, I have several of these. We won't get terribly grossed out here, but prepare yourself. That's all I'm saying.
This is Dr. Stephen Cohen, and you're about to see a video of a complex retinal detachment repair. This patient had several surgeries for his retinal detachment, most recently a month ago. Unfortunately, the patient had an area of subretinal fibrosis form about a month after his retina was reattached, and the only area of the retina which had not been previously detached, and that's the reason this surgery became necessary. Since his last surgery was only a month previously, you're seeing the previous surgical incisions being reused. Here the suture is being pre-placed for an infusion cannula, and no incisions necessary. The infusion cannula is just being pushed through the previous incision site.
No big deal.
This patient had been referred into the practice for complex retinal detachment repair after having had several surgeries done elsewhere, and the surgery that was done a month previously required silicone oil. Now the first step to this surgery is removing the silicone oil which was placed in the eye a month ago.
Now, I know the little classical music there is very confident, but notice what he said. He said the vitreous humor had been removed and replaced by silicone fluid. And now they're removing the silicone fluid to continue this procedure.
Sounds like Vivaldi.
We use a special high pressure pump to remove the silicone oil, and there you see the last few drops of the silicone oil being removed through that blunt tip needle. This patient has a very small preretinal membrane which is being removed here. There you see the tiny membrane being taken from the bead. Here you're seeing interocular cautery spots being placed. These help prevent bleeding. They also weaken the retina, and they also provide a marker so that once the retina is reattached, the boundary can be easily visualized so the laser can be placed later.
He's just putting down landmarks.
Here you're seeing the last few droplets of silicone oil being removed from the anterior chamber. This helps clear the view for the future maneuver. Once the oil is removed and the cautery is placed, a retinotomy is made in the far peripheral retina. Here the retina is actually being cut. You can see the path being made by the vitrectomy instrument, which is cutting the retina. This will allow access to the subretinal space to remove the subretinal fibrosis. It also will help relax the retina and make it easily attachable later in the surgery. Like most of our surgeries, this procedure is being done under local anesthesia with sedation. The patient's comfortably anesthetized, and the eye's been heavily anesthetized with Narcan and lidocaine prior to the surgery.
That's comforting. So what I was going to show you is the final portion.
At this point, the retina has been reattached. The silicone oil has been used to refill the eye. That will hold the retina in place while the laser heals. This patient's had so many problems with retinal detachment, the silicone oil will probably be left for at least a year, and it may be necessary to leave the silicone oil in the eye permanently. Patients can see through silicone oil, it's transparent, and in this situation, since the patient's lens was removed in the last surgery, the patient would need either a contact lens or another lens placed in the eye to help focus and see properly. That'll be done probably in 6 to 12 months.
So, another remarkable procedure. Another one, is this the one? No, I guess that's not it. Yeah, this is a little animation on cataracts. They misspelled, it's not sugary, it's surgery.
During this procedure, your surgeon will first create a small incision with an advanced diamond cutting tool. Your surgeon will then peel off the front layer of your lens capsule. Using ultrasounds from a small, sophisticated instrument, your surgeon will break up your cataract into minute fragments.
If the music didn't comfort me, I'm relieved at the fact that the instrument is sophisticated.
These fragments are then gently suctioned out of the eye through the instrument's tube. An intraocular lens is then implanted to replace your natural lens. For more information, ask about cataract treatment.
Yeah, in cataracts, of course, there's protein accretions, proteins obstruct the field of view, and that is another virtually inevitable component of aging. Could be learning, isn't it? All right, so I think that's all I wanted to show you there. You know, that's pretty gross too. The cataract, the LASIK surgery, laser surgery for cataract, where they're shaping that stromal layer of the cornea. It looks bad, but it's actually not as bad as the other procedure. And then you're good to go.
Wow.
All right. So as I say, what I'm going to do now is move on to the neck, because we'll talk about the ear in the physiology class. So I'm going to move on to the neck. Let me know if you have any problems bringing this one up. You will be relieved to know there are only two of these. The head is the longest of our units, I thought. No, we're not doing the last head. That was the ear that we're going to skip over. We'll talk about that. No. Not in here. All right, so we're going to look, we're moving south. We're looking at the neck now. You can see a transection of the neck here. So we'll talk about the first, oh, I'm sorry, thank you. I'll talk about it. Okay, so we see the transection of the neck, and we'll talk about the compartmentation of the traditional way in which the components of the neck that you see here are compartmentalized, and this is done in a variety of ways. You can see over on the right, too, you can see there's a sort of palpation of the neck. You can see sort of putting the finger between the scalenes there, palpation of the carotid artery. Some of these procedures, I'm told, aren't so used as much these days. But you can see that the jugular and carotid all right there clustered together. And if you've ever watched a gripping crime drama, sometimes the criminal, the very nefarious criminal, will know, for example, the 7 death grips, and will know exactly where to put his fingers on the victim in the elevator standing behind him, and the victim immediately expires. But that's what they're doing, just to liven up today a little bit. It's something to try in the elevator this afternoon. formally, the anatomical perimeter boundaries of the neck, and by the way, a lot of these regions overlap, approximately from the nuchal line posteriorly down to about C7, which is the spinous process of C7. And then anteriorly, the neck would go from the chin all the way down to the clavicles. And here you can see some of the surface anatomical structures, which I think all of you can identify now. You're familiar with the angle of the mandible, the mental protuberance. We'll talk at some length about the hyoid bone here. We'll talk about the cartilages that make up your voice box, the larynx there. You should be able to palpate and identify all of those structures with your fingers. And then you can see the clavicle inferiorly. This should look familiar to you. Of course, we're looking at the ascent of the common carotid and the vertebral arteries. And all this is telling you over here is that there are a number of important anatomical landmarks at about C3 and C5. At about C3, C4, you have separation or division of the common carotid into the internal and external. And then at about C5, C6, that's about the level a little farther down of this, a little farther down of the margin between the thyroid and the cricoid cartilages. And once again, that can be very important for tracheostomy procedures of that sort. The perimeter of the neck, the outermost layer of the neck is sometimes just described as superficial fascia. It includes subcutaneous adipose tissue, but also includes, surprisingly, this thin layer of muscle we've encountered before called the platysma. And that's because this platysma is so thin. It's such a diaphanous layer. And remember, the platysma is innervated by the facial nerve. In fact, there are some authorities that argue that the platysma is simply a vestigial tissue used exclusively for the purpose of sexual selection. That being able to do this somehow enhances your attractiveness to the members of the opposite sex. So I go in the office every afternoon. As you look at the transection here, and we'll look at this slide or one like it on several ensuing occasions. But what I want you to pay attention to is notice most of the volume of the neck is the neuromusculature surrounding the spinal column. So that's the posterior. We'll talk about the compartmentation in a moment. That's sometimes called the vertebral compartment. But that's it. That's mostly just the bone and nervous system and associated musculature. And then anterior to that, where we'll be spending much of our time, we'll be talking about several fascial membranes, and you can see several of them here. We need to talk a little bit about those membranes. And then, of course, the relationship of the esophagus and the trachea. And we'll talk a little bit how all this is regulated up here as well, how the epiglottis helps to facilitate breathing and deglutition. So let's talk a little bit about this traditional compartmentation. So, posteriorly, you can see you have this muscular compartment along with the vertebra. Oops. And you can see surrounding that are these green fascial membranes that are sometimes just called investing layers of fascia. These are the fascial membranes that, for the most part, encase the musculature of the neck. Pre, you know, means anterior to, so there's a prevertebral layer, sometimes involved with the muscles that you sort of see in this region right here. That would involve, for example, the scalenes, for example. You have the pretracheal layer. Here's the trachea here. This whole region here is sometimes called pretracheal. And that would include the esophagus, the trachea, and the thyroid gland that you see there. And then the two carotid sheaths that you see here. These are sometimes called carotid zones that include the jugular and the carotid, associated lymphatic and nervous structures. An alternate terminology, again, describes all of this as vertebral. All of this muscle and bone back here is vertebral. And then you have this portion up here that includes the two passageways, the esophagus and the trachea, along with the glands up here. That's called the visceral layer. And then once again, these vascular compartments laterally containing the jugular vein and the carotid. Now, I thought we were going to, okay, so let's look at this. This comes up again later. So again, I guess I'm not sure why I put it here, but let's look at some of these membranes that separate the visceral layer from this vertebral layer here. And the names are fairly straightforward. So if this is our vertebral layer here, the fascial membrane that's immediately anterior to the vertebral layer is called the prevertebral fascia. Prevertebral fascia. Anterior to that is a region called the danger space. And you might ask yourself, why is it a dangerous space? And then anterior to that, you can see this sort of pink membrane here, which corresponds to the pink membrane down here. So this pink membrane here and the pink membrane here, that's the alar fascia. And you already know what the term alar means. And then this term has a logical term too, retropharyngeal, behind the pharynx. That's your retropharyngeal space there. And then anterior to that is the buccopharyngeal fascia. Now, both the retropharyngeal space and the danger space are membranous systems that extend from the thoracic cavity up to the head, and they get their names, or at least they acquire their reputations from the fact that infections, viruses, bacterial infections, and any number of fungal infections can pass between those two compartments by means of the spaces in the neck here. So that's why it's called the danger space. All right, so if your day isn't livened up by watching eyeball surgery and discussions of danger space, I don't know what will. So we'll stop there.